All right, thank you very much. No videos, so those are really fascinating to watch, having never seen that before. We'll switch gears and go back to scars, burn scars. Dr. Donnell and I have worked on this topic together for many years now, and I think we're still making progress and still learning. So, why do we care? Well, hypertrophic burn scars can really severely impact the quality of life. You know, once somebody has been discharged from the burn center, they're now facing a life of scars that they're going to have to deal with. And the symptoms can be variable, but they can include pruritus, dysesthesias and paresthesias, stiffness and contractures, infections, even the abnormal or the lack of ability to regulate your temperature, and of course, poor cosmesis. So this is a paper that we presented 10 years ago now. This was a fairly seminal work that looked at our initial experience with lasers and burn scars, presented at the American Surgical in Boston. And in this paper, we looked at 147 patients that we treated over a year period, over 415 sessions, about 3 sessions per patient. And then we did a follow-up on this group of patients as well. So we collected data not only at the end of that year, but then also 3 years later in 2013. These were young patients. There was a nice mixture of Fitzpatrick skin types, but these were large burns, 16% TBSA. And the areas that we treated in this study were fairly small, about 83 square centimeters. Complication rates were low, nothing major, and again, our long-term follow-up I've already discussed. So the laser platforms that I used at that time included pulse dye laser as the most common, but also fractional CO2, some IPL, and alexandrite and diode for some other indications such as hair follicles and the retained elements in the skin. So at that time, this was about 2/3 PDL, 1/3 CO2. And we reported that essentially after one session with all the lasers combined, we were able to decrease the Vancouver scar score significantly from around 11 down to 7, just with one session alone. And then if you look at all the sessions, which were about 3 to 5, depending on the cohort, this further improved these patients. And then our long-term follow-up 3 years later showed that the scars continued to improve despite having had their lasers stopped. We also developed the UNC 4P scale at that time. This is a subjective version of a patient-reported outcome. This included paresthesias, pliability, pain, and pruritus. And we also demonstrated a fairly dramatic impact on our symptoms. Again, you can see here pre-op UNC 4P scar of about 5.5. We got this down to less than 3 after one session, but continued to improve, as I've already mentioned. And this was one of the patients from that series that I've shown at previous meetings. So this was her in 2011. She was 15 at the time and had been in a propane explosion at her mom's food truck. She sustained about 40% TBSA burns. I took care of her somewhat when she was in the hospital. She developed a DVT, but overall was discharged, and you can see here the magnitude of her scar burden on the left. And through a combination of lasers, steroid injections, and tissue rearrangements, we achieved the result on the right. And I have to echo what Dr. Donnell said. All of these things have to be done in combination. They work synergistically, and especially doing little things like these Z-plasties to take tension off the vectors of force. And here she is on her side view. I have to admit, when I first sat down with the family, I was very concerned, but I was gaining experience with the laser, and Dr. Donnell just urged me to stay the course, not excise things, just try to rearrange what she already has. And here she is from the oblique view. And interestingly, this really put her on a trajectory in her life that she wouldn't have gone on. She met the dean of the School of Journalism at UNC. They did a featured paper on her, and she was accepted into college. She graduated in 2018. I mean, she was the first person in her family to ever go to college. And there she is just a couple months ago. She's now a radio announcer down in the Fayetteville area. And in fact, I am going to be having coffee with her on Thursday of next week. And I haven't seen her in years. So that's really exciting. So we went ahead and with this information, before I left UNC, which was in 2018, I looked at my last year's worth of experience with lasers, and I wanted to see if we were still having the same results with our combination of lasers. So this is a study period basically in 2017, 204 patients, 377 sessions. We did present this in Baltimore, I think it was in 2018, 2019, as I just showed. And again, complication rate remained low, shorter follow-up period. And by this point, almost 10 years later, our algorithm had changed. We were doing far more fractional CO2 at this point, but pulse dye laser was still a very important part of our practice. And again, some patients with alexandrite and diode. But now you see this shift to fractional CO2. And what we did this time is we had enough data that we could then look at the results from PDL and look at the results from fractional CO2 as two different cohorts. And we found that both lasers were effective. Now, I will also tell you in this session, we had an algorithm that we used that would predict if we use pulse dye laser or fractional CO2. My practice has since changed. I do both now at the same time. But back then, patients were randomized into, or not randomized, but they were directed into one of the treatment arms. And we see here that, interestingly, PDL didn't really have much of an effect on the UNC 4P score. Remember, these are patient-reported outcomes, but fractional CO2 had a much bigger impact at that time with this patient group. So I think that was an interesting differential. And then this is a patient that was part of that series. This is also a very interesting story. This is a woman who in 2014 was in a house fire. It might have actually occurred in 2013. She was in nursing school at the time, getting ready to graduate, and we began treating her in 2016, 2017. So you can see the difference from before and after, although I wouldn't say she's that much better, but the scar has changed. The scar's actually gotten bigger, but it's gotten a lot flatter, but it remained really red. And so I was getting frustrated. I wasn't able to, get her to where I wanted her to go. And so, Matt, I did some tiny little Z-plasties around the periphery of the wound and some W-plasties. And here she is in 2024. So she is now a nurse at my hospital, my new hospital. I got a call that there was a nurse in the PACU who wanted to see me about my patient. So I come back to see my patient, and patient's doing fine. But the nurse is the same patient that I treated 10 years ago. It was a great story, and I was shocked at how better her face looked. She promised me she didn't go to any other plastic surgeons. But this is sort of the natural gradation of her scars over a 10-year period. And this is not that dissimilar to what Dr. Dueling was showing us. And here she is on the lateral. And you can almost appreciate, if you look at the far right, at the base of her neck, you can see the tiny little Z-plasties that I put in the scar just to break it up so she didn't have a line of tension. So I am now getting closer to the last couple of years of my career. I was at UNC for 18. I came to Hopkins for 4.5 years, and I'm now back at Campbell in North Carolina, which is a new medical school. And I was given an offer I couldn't refuse to go down there and start a department of plastic surgery. This is a community healthcare system. And I told Dr. Dueling that I was going back, and he's like, "Why are you leaving academia?" And I said, "Well, I don't know if it's leaving, but I am going back home." And he said, "Well, you're going big and you're going home," which is a great way of putting this. So I have since developed a pretty big practice. I take care of about 20% burn patients. I'm going to just warn you, the next patient I'm going to show is a little bit triggering. So, and I'm not being sarcastic. It's one of the first patients I took care of. It's a very sad situation. A woman was abducted, mutilated, and stamped. And her ex-boyfriend specifically stamped her groin. And so she and her mom came in to see what they could be done about this. And they wanted to excise this, and I thought it was too large of an area to excise. I'll show you the picture in a second. She also had previously had mental health issues, and she had self-mutilated herself. So she's got multiple scars all over her legs. So this is her. We decided to go with lasers first before we did anything surgical. And I was very aggressive with this. I used pulse dye laser, fractional CO2. This is after 4 sessions. I did intralesional and topical Kenalog, and you can see the progression now. This was done every month. for 4 months, and then she fell off my radar last year. So I have not seen her since November. I'm hoping that last little bit has improved, but this area where she was branded by her ex-boyfriend is now, hopefully now, just a bunch of scar tissue that if anybody sees this, they're not gonna, know what happened. So I wanna finish with this case. These are the kind of wounds that I take care of now. This isn't a burn. This is a woman who went to the community golf course and met up with some strangers, and unfortunately, as she was getting out her pitching wedge, the golf cart behind her slammed right into her golf cart, and you can see here now she has this open fracture of her tibia. So she underwent IM nailing of the tibia. She necrosed that entire skin flap. Then orthopedics called us. So I went ahead and debrided this. I treated this with a xenograft initially, just to get this is fish skin. Now, normally a wound like this would probably need a free flap. Okay, so we're looking at heavy contamination, open fracture, hardware. But I wanted to see what I could do with these technologies. So we did a fish skin, a couple rounds of that. And then I did spray-on skin, which is another interest of mine. And so here she is at one of her first dressing changes. You can't really tell that the skin has been sprayed on, but you're seeing early hypertrophic scar formation in that second picture from the left. And that's one of the concerns about spray-on skin, is that we're not really spraying on much dermis. It's all keratinocytes on top of a widely meshed graft. And just as an aside, these patients do very well overall, but there's about a 5% incidence of hypertrophic scar. And so I now have the experience to know that I need to jump on this patient very quickly to treat her so that this doesn't get worse. And you see there, second picture from the right. This is right before we started doing lasers on her, but I hit her pretty hard with pulse dye laser, fractional CO2, topical steroids, and then 4 or 5 sessions later, you see on the far right. At this point, she had been having a lot of chronic pain, not that unusual given her injury, but as I was telling our panelists before the session started, chronic pain is one of my interests because I look for an anatomic cause. And so now that a lot of her traumatic pain is gone, she has neuropathic pain. And so you can trace out the superficial perineal nerve where she has a Tinel sign. So I went ahead and did a release of that superficial perineal nerve, but then I also did a percutaneous release of the sural nerve, and I did fat grafting around that. And then the actual nerve that was released, we wrapped that with a collagen tube. So she's doing pretty well from that regard. I do want to show you too the evolution of her donor sites. This is an iatrogenic injury. Wrap up? Yeah, this is it. So you can just sort of see that with fat grafting and lasers, and that's it. And this is my algorithm. If you want to take a picture of that, you can. It's all about whatever you're trying to target, and I'd be happy to answer questions later. Thanks.